Okay, so I think I was just going to say, I think we should be able to start now. Bob, if you can hear us, can you unmute and at least talk to the group?
Hey, good afternoon, everybody, and thanks everyone for joining either in person or virtually to the fall meeting of the Barlogie-Salmon Myeloma Committee. I'm working distantly today and would like to thank very much the AV folks for setting everything up, and particularly to Christine Yee and Sikandra Ilawadi for, I think, leading the discussion today, and I'll turn it over to them to talk about all the exciting things going on. Thanks very much.
Excellent. So with that, let's start off the meeting. And so here, I guess before we go into the studies, we're just wanted to share with you some of the exciting work that has been going on with SWOG. So this is just showing you the list of enrollments in clinical trials by 12-month intervals, and you can see clearly how we have been doing better over the past couple of years. The accruals have really been going up nicely. I guess that brings us to a very important responsibility of keeping that going, and of course, we'll have to change the scale of the slide to accommodate the 2022 numbers, I guess. But with that, we'll just come up to our first study with S1803. I believe we have Dr. Krishnan and also Saurabh is on. Dr. Chabra, they should be on. So either one of you, will let you guys take on, please. Start off.
I can go, Dr. Krishnan, if it's okay. Should I share my screen?
So, Saurabh, you can just ask us to advance the slides and we have them. We'll be able to move them.
Perfect. So thank you for this opportunity. My name is Saurabh Chabra. I'm at Mayo Clinic, Arizona, and I'm here to provide you an update on the SWOG S1803 clinical trial on behalf of my senior colleague and study co-chair, Dr. Amrita Krishnan. So S1803, as you know, is a phase 3 randomized trial investigating single-agent lenalidomide versus lenalidomide plus subcutaneous daratumumab as maintenance therapy following autologous transplant for multiple myeloma. And in this trial, adult newly diagnosed myeloma patients up to 75 years of age who are within 18 months of starting induction and without progression at any point since diagnosis are eligible. This trial has 2 randomizations. Next keystroke, please. Patients are to undergo, So the patients are to undergo first randomization to len or len-dara within 180 days from autologous transplant. MRD is assessed using next generation sequencing using the clonoSEQ platform prior to the start of maintenance and then annually. And randomized treatment is supposed to continue for 24 months, at which time point patients who are MRD negative at less than 10^-6 undergo a second randomization to either continued maintenance on their assigned arm or discontinue maintenance. The primary objective of the study is to compare the overall survival between lenalidomide and daratumumab as the experimental arm and single-agent lenalidomide as the control arm. The objective of the second randomization is to compare the overall survival of MRD negative patients who continue maintenance on each arm versus those who discontinue. Next slide, please. I will skip this slide in the interest of time. Next slide, please. So an early readout of the trial will be 24 months MRD analysis, which will be as early as 24 months after all the patients have been accrued. And here's a timeline of the milestones for the trial. And you can see at the bottom, the first patient was enrolled in September 2019. A total of 1,100 patients are to be accrued to step 1 to allow for a 5% dropout so that we have 950 patients for the first randomization. And as of now, 955 patients are enrolled in step 1, of whom 873 have undergone first randomization. 30 patients have made it to the second randomization at this point. Next slide, please. So here we see the accrual trends since September 2019. The initial projection was that we would see 13 to 14 patients enrolled on the trial on a monthly basis. But as you can see here, accrual has certainly exceeded our expectations. Next slide, please. Here's a list of the top 12 enrolling sites with more than 15 patients enrolled, starting with City of Hope, with a whopping 90 patients, followed by WashU at St. Louis with 44 patients, and Medical College of Wisconsin with 43 patients. Next slide, please. Here are some of the recent updates over the last 6 months. We are excited that our Canadian colleagues have joined the trial. The trial was actually activated in Canada earlier this year, and as of now, 2 sites have been activated. There was a quality of life amendment, which was approved in revision 5 in May. And in revision 6, we addressed 2 important issues, which was approved last month. One of the issues is managing cytopenias as toxicity of maintenance therapy in patients with Duffy null phenotype. And the second was the need for obtaining a baseline archival sample for clonality ID from the time of diagnosis of myeloma to be able to do MRD testing later on in the trial. We also have a revision 7 in the works that pertains to use of HydraShift 2x4 daratumumab assay to evaluate the biochemical response more accurately. Next slide, please. So we know that individuals of certain minority ethnicities can have persistently low neutrophil count without significantly increased risk of infection. And this condition has been referred to as benign ethnic neutropenia, which is correlated with homozygosity for a SNP in the promoter region of DARC, which stands for Duffy antigen receptor for chemokines gene. And that results in the Duffy null red cell phenotype. So the Duffy antigen acts as a cytokine sink that binds to the inflammatory cytokines. So Duffy null individuals have fewer neutrophils in the periphery, but they have normal marrow cellularity and maturation, and they respond robustly to infection. And red cell phenotyping is the best way to identify benign ethnic neutropenia rather than race or ethnicity. Current evidence indicates that the risk of febrile neutropenia due to myelosuppressive therapy is not increased with Duffy null phenotype. So having a rigid high neutrophil count reference range that does not reflect Duffy null phenotype can limit the access of certain patient populations to cancer clinical trials. The evidence also supports that careful blood count monitoring and prophylactic use of growth factors would provide sufficient safety for Duffy null individuals in clinical trials, and we can achieve that through explicit changes in eligibility and dose modification criteria. So in S1803, we have used an ANC of more than 1,000 per microliter as a starting point for maintenance for all patients, but for Duffy null individuals, we will aim to maintain ANC more than 750 and modify the len and dara dosing accordingly, as shown in the tables. Next slide, please. The other issue that we have encountered so far is that we have had patients who we did not receive a baseline archival sample or commercial B-cell clonality ID on. And so these patients will not be able to undergo second randomization since we won't know whether they are MRD negative or not. And we saw that in 24% of the patients who had first randomization. In addition to that, we see 18% of the samples that were received failed quality control or were found to be polyclonal. Therefore, we have amended the protocol to allow only those patients who have a baseline sample available or have commercial B-cell clonality ID available to be eligible for the trial. And that was done in revision 6, which went into effect earlier last month. Next slide, please. And lastly, as we know, daratumumab is a IgG kappa monoclonal antibody, which can co-migrate with the disease-related M protein and can lead to false positive results on immunofixation in patients with IgG kappa myeloma. So HydraShift assay, which is FDA approved, uses an anti-daratumumab antibody to shift the migration of daratumumab anti-daratumumab complexes towards the alpha globulin fraction on immunofixation, and therefore overcomes interference by daratumumab. So essentially, HydraShift assay can distinguish daratumumab from disease-related IgG kappa M protein on immunofixation and allow assessment of the M protein without the dara interference, as shown in the top panel. And in other cases, it can show that immunofixation is actually negative after removing daratumumab from the equation as shown in the bottom panel. And we're expecting that revision 7 to be approved soon, which amended the protocol to include hydroshift assay to be done in patients with IgG kappa who are in very good partial response. Next slide, please. And with that, I will stop, and I'm happy to take questions.
I'll ask one quick question. What do you think will be the impact on enrollment of the new requirement that the baseline sample be available, just in terms of calculating the future completion timeline?
That's a great question, Dr. Orlowski. So I think what we are considering now is going back to the statistics and trying to figure out if we need to increase the sample size to account for the fact that we don't have as many patients we would be able to do MRD testing on. So this is being conducted, being done right now, and I hope we will have an answer soon to that. We are also going back to the sites and asking them if they can provide another sample on those patients who we did not get the sample on, or there was a test failure. So, but I think it is quite likely that the sample size would need to go up, and that would delay the timeline for the completion of accrual on the trial. And I will ask Dr. Krishnan as well if she had anything to add.
Thanks, Arb. I think Bob's question, if I understood it a little bit differently, is I mean, to your point, we are planning on increasing accrual to the trial, and it is more that is that accrual number per month going to go down because of this requirement to have that baseline MRD sample. You know, I mean, even our own center, I can speak to, it certainly has been challenging, but we've been pretty proactive about that with our coordinators, given that they know this sort of from up front. So, you know, I think it's a sort of a messaging in regards to each center, you know, certainly bringing that back to their team to have a heads up if you're even thinking about this protocol for your patient, to put that process, to start that process already of getting those baseline samples, because to your point, many of them, the baseline marrows are done at outside institutions.
This is Hannah. I'm the data coordinator for this study along with Daria. We've not noticed any change in accrual in terms of going down. It's actually seemed to have gone up since we've put out this amendment. I don't know if it's related to that or not. I would doubt it, but we have not seen any impact negatively by adding in this additional requirement.
This is Jack. I have a question. Was there ever any consideration for using flow at 10 to the -6, say sending samples out to Mayo and such, to capture that MRD status for the 300 that we don't have good information?
So, I mean, I think two things, Jack. One, obviously, it's really at the 2-year time point, since that now it's becoming apparent, right, that these patients, as we, you know, as we try to run that analysis. So, you know, I think, you know, in terms of, is your question that should we then amend the protocol to then allow for a fresh? I think the challenge would be, in the absence of then having that at each time point and having, you know, the argument of validating that comparatively to the MRD by NGS sequentially. And that was actually something we had discussed at the beginning, is actually at each time point doing both. but that frankly was a cost issue as well. So I don't think we could suddenly pick a different method for that subgroup of patients.
I just wondered if it would be any more cost effective than recruiting another 300 patients.
Well, I mean, I think it's not just cost, though. It's also in regards to the validity of our analysis, right? If we change our methodology for a group of those patients.
I think the other consideration is that the way the flow is done, the sensitivity is not always comparable to what we get with the next-gen sequencing. And so there's a potential for some confoundation there.
Thank you both.
Okay. Excellent. I think with that, we'll move on to the next study, but I think kudos to everybody on the cooperative group to be able to enroll patients so well that we are actually talking about increasing the accrual to be able to meet those endpoints.
I was going to just ask, a lot of times we do postmortems on studies that don't accrue well. I think it would be really nice to understand why this one is doing so well.
Sure.
We could try to figure out what's the reason so we can do it again.
Sure. So I think for everybody, I don't know if you heard it or not on the Zoom, but Dana Sparks is suggesting that we keep looking at all the trials where we don't accrue well and keep thinking why we didn't do well, but there's room for us to figure out why 1803 has done better than expected because we're setting new benchmarks for ourselves. Actually, Dana, from that standpoint, we've floated the idea a couple of times that historically cooperative groups have been considered slow or studies go slow, et cetera, and that's where we probably also are thinking about pooling our data and looking at just a protocol life cycle and a study life cycle within cooperative group and how we tend to do good. Now, we've had several examples of trials where we've done better than what we had expected. So Patrick and I are talking about potentially looking at that, pooling our data and bringing it out as a publication to show how cooperative groups can actually be a very efficient and effective mechanism to run large clinical trials and be successful, and that are potentially like this practice changing. So excellent idea. All right. So if no other questions with that, we'll go on to the next study. So I'll present this on behalf of also Divya, who's my study co-chair for this. This is a protocol concept S2005 for Waldenstrom's macroglobulinemia, newly diagnosed patients. We've had this concept with our committee for quite some time, and actually the study was activated earlier this year, but then had to be put on hold. Christine, next slide, please. Actually, I can. So the study was initially designed as a comparison between ibrutinib Rituxan as the standard versus ibrutinib Rituxan with venetoclax as the study arm. It was a randomized phase 2, was actually activated for newly diagnosed patients. Patients were allowed to have Rituxan as a single agent as long as it was several months ago. But then the study, as we activated it, and there was actually one patient put on trial at Sloan Kettering. We were all pretty excited that the study had launched and we were looking at patients, but we found out about some safety signal with respect to IRV, ibrutinib Rituxan venetoclax, which was a single arm phase 2 study being done by Dana-Farber. And there was some cardiac safety signal that came out of it. And there were a couple of actually grade 5 events. So there were a couple of deaths also in that study. That study was immediately put on hold. Patients were taken off treatment. And since we had a study arm exactly the same, we also put a hold to our study. We spent quite several weeks to a couple of months trying to look at the data, even individual patient level data, or collaborating with Dana-Farber to understand, but I don't think we were able to find any specific pattern. So we thought about including cardiac workup, et cetera, but Dana-Farber had done that with amendments. Still, some of those events had happened. So eventually, we took the study back to the drawing board, and we came up with this alternative design of comparing IR with IV, which is just a 2-agent study as well as standard arm. So that patient, the one patient who was put on trial, was on the safety run-in cohort, was actually taken off and then switched over by Sloan Kettering to standard of care treatment. So the new trial design we're talking about, this is the amendment that is currently being drafted. It would be, again, a randomized phase 2. Arm 1 would be ibrutinib Rituxan, which would be the standard of care arm. And then the arm 2, or the study arm, would be venetoclax Rituxan. It's no longer a 3-drug regimen, but it would be a 2-drug regimen, so 2 versus 2. Treatment would still be given for a fixed duration of 2 years. We've really talked about giving a fixed duration treatment rather than till progression, et cetera, or ongoing. And now the study will have a crossover component. So patients who are on treatment, and if they have any progression, the IR will go to VR and the VR will go to IR. So we will have that to try and capture some of that sequential treatment question also, which keeps coming up, not just in, let's say, Waldenstrom, but in everything we do. We talk about that sequential treatment component is somehow never captured, or it's not always feasible. And then the patients go off protocol. We'll continue to follow them for up to 5 years from registration. This is just pointing out some venetoclax-related experience where single-agent venetoclax has been studied in relapsed refractory Waldenstrom, small phase 2 study. And the response rate was, overall response rate was 85%. The VGPR rate was about 19-20%. And then venetoclax was quite well tolerated, not any significant safety concerns. And importantly, there was no cardiac toxicity noted by itself in that study. This was again a study done at Dana-Farber, so that made us feel that the cardiac signal that was coming without finding any other objective evidence was somehow coming from that 3-drug combination. Now, I can tell you that we've looked at that in data from CLL, from lymphomas, et cetera, where ibrutinib, venetoclax, that combination has been used, but that kind of an occurrence was not noted anywhere in other diagnoses. And considering the natural history of Waldenstrom, we thought that it was not appropriate for us to pursue that 3-drug combination, even if there was one event of significant cardiac morbidity or, unfortunately, in the extreme case, death. We just decided that was not the appropriate end point. So that's where I've mentioned the rationale of the new study design. It is based on safety reasons. It'll be 2 versus 2 drugs, but of course in the newly diagnosed setting, so we expect that the outcome would be better of using the BCL2 inhibitor in the newly diagnosed setting as compared to the single agent study that was in the relapse setting. It would be limited duration, and as we mentioned that we do not expect any cardiac issues there. So again, I've gone over most of this information, the 2 versus 2 drugs, treatment for 2 years, crossover arm built in, the crossover portion, sorry, built in, and then cardiac assessments will be added. And importantly, the primary objective for the initial study was a complete response rate. But we kind of thought that with the going from 3 drugs down to 2 drugs, we were not sure if the complete response was a very achievable primary objective. So we did change it to VGPR or better. So VGPR or better as the primary objective, still a bunch of secondary objectives where we're talking about overall response rate, PFS, time to next treatment, CR, safety, time to VGPR, overall response rate, and overall survival. The inclusion-exclusion criteria are listed here. We have said that actually we did end up making a slight change that the rituximab allowed if it was given at least 6 months. So single agent rituximab use prior would be allowed if it was at least 6 months prior. And the rest of the inclusion criteria are quite standard. The VGPR rate, if that was to go from 25% to 50%, we picked 25% because with single agent, venetoclax in the relapse setting was able to give 19%. So we thought in the frontline setting with Rituxan, 25% was a good number to pick. And the study arm, for the ibrutinib Rituxan. And for the study arm, we thought that if it was to go in a combination in newly diagnosed setting, it may be reasonable to test if we would be able to get to 50% VGPR with venetoclax Rituxan or better. So based on this hypothesis, we would need 33 patients in each arm, total of 66. So the total accrual target has gone up slightly higher with the VGPR primary objective. and 80% power to reject the null at 25% VGPR rate. There will be an interim futility analysis that will be built at half the patient accrual with a VGPR at 6 months of treatment as the marker. So I'll stop with that. Any questions from anybody, either in person over here or online through Zoom? And of course, any feedback from any of the SWOG members, if there's any feedback you have for any of this, please feel free to jump in or reach out to the study chairs with any kind of feedback or comments. Okay, so I guess we haven't had any questions with this, so we'll go on to the next concept then, something which has also been worked upon for quite some time, and maybe this is, again, from myself as the study chair and my co-chairs, both Dr. Yee over here and Brea Leip, who might be on Zoom, I guess, from University of Rochester. So this is for a newly diagnosed phase 3 trial of frail or a subset of intermediate fit newly diagnosed myeloma patients, comparing upfront 3-drug induction regimens followed by double or single agent maintenance, S2209. And we're finally very excited because hoping that this will get activated very soon, within the next, hopefully, couple of months. We're waiting for just the CIRB and NCI final approval. So we've been discussing this study at the meetings for a bit now, but just to recap quickly, there is an unmet need in the frail and real-world patients in newly diagnosed myeloma. I would underscore this real-world patients because, as I'll be able to point out, we have spent a lot of time and effort to make this study as close to real-world practice as possible, so that age-old question about not having a real-world population being represented in the clinical trials, hopefully we'll be able to get over that issue. VRD Light is a widely accepted regimen before Daratumumab got approved, and then Dara-RD also got approved based on the MAIA trial, both with PFS and overall survival benefit as compared to RD. Patients in this category are often actually considered ineligible for prospective clinical trials due to very strict inclusion criteria and are just excluded out of trials. So introducing practical inclusion criteria to maximize study enrollment from this group and focusing on a real-world newly diagnosed myeloma patient population is something that we've kept in mind throughout while we have been designing this study. And in fact, I would say that's where Christine and Brea, myself, the stats group, whenever we discussed any portion of this trial, that was the underlying guiding principle. How can we make it as close to real-world practice as possible? Because frankly speaking, these regimens are FDA approved. So what can we do to get every single myeloma patient who walks through the door in our clinics with newly diagnosed myeloma to be able to get onto the study? So this is the study schema. Again, arm 1 would be VRD Light, followed by lenalidomide maintenance. Arm 2 would be DRD, followed by lenalidomide maintenance. Arm 3 would be DRD, followed by Dara-Len maintenance. I'll just point out the reason for having it set up this way, because while the MAIA trial had the patients stay on the full regimen forever, till progression or whatever, but there is a lot of data from real-world analyses, including Janssen was able to have discussions with us that in the real world, patients do not stay on Dara, Len, Dex for that long. And typically 6-ish months, 7 and 8 months after starting, the drugs start getting dropped off. Dex stops, Dara stops, and most of the patients get maintenance with single agent Len in this setting. So we thought that it was important to have arm 2, which was be representative of what is happening in the real world right now. And arm 3 would be potentially the ideal case setting for the DRD. And hopefully this study would show us what's the best way to use these drugs in this patient population. So 9 cycles of induction in each of the 3 arms, and then the maintenance built in after that. I should also point out that this VRD Light is slightly different from the VRD Light that has been previously published, because after gaining a lot of feedback from those on this room, SWOG committee, the membership, this particular VRD Light regimen came up because this was apparently the most common version being used today for these patients. So we thought, again, the regimen should be what is being used. The stratification factors are frail versus intermediate fit as classified by the Myeloma Frailty Index, presence of one or more of the cytogenetic abnormalities of the high-risk markers, and any systemic anti-myeloma treatment pre-registration, because this trial does allow the patients to get a little bit of pre-registration treatment. Again, understanding that when patients come in, they have a high disease burden. Sometimes clinical trials are not the obvious thing in mind because the patients have to start treatment right away. How can we get those patients on treatment as well? The study has dual primary objectives. Both PFS and OS are primary for the study. Again, thinking a little bit out of the box, this is where kudos to the stats team because they helped craft this so that it's no longer just we're looking at PFS or OS, we're actually looking at both as the primary endpoints. And that's where arm 2 is going to be compared with arm 1 as the PFS endpoint, and arm 3 is going to be compared with arm 1 as the OS endpoint. And either one of these come out significant, the study would be a positive study. There are, of course, quite a bit of secondary objectives. PFS of arm 1 versus 3, OS of 1 versus 2, again, the ones that are non-primary. We will be comparing the PFS in the second arm 2 and 3 also. So DRDR versus DRDDR, that would also be compared. Overall response rate, safety, median time to response, and incidence of venous thromboembolism, so VTE. And I'll maybe point out there are a ton of sub-studies that we've planned with this. There is quality of life, which we feel is extremely important for this patient group. This is going in as a part of the clinical trial. It won't be added later. And we thought this was the one piece which was extremely important, so it is being built into the protocol before the protocol activates. So this PRO component will be built in, and Dr. Christina Gowan from University of Arizona is our PRO lead on the study. And then the quality of life questionnaires are there, but we'll also be asking some patient-reported outcomes on CTCAE criteria for fatigue, neuropathy, and pain. MRD assessment will be done, which will be done as a standard of care using clonoSEQ. And there are some MRD-related objectives there. There are tissue samples will be backed. Christine Yee, who's my study co-chair, is going to be leading the translation medicine component. Right now, as the study goes in, the samples will be banked, but she's working on crafting the TM proposal, which will be activated hopefully soon thereafter. I will quickly point out eligibility. As I said, it has been designed to mimic real-world practice quite a bit. So patients, for example, can go on with any creatinine clearance as long as they're not on dialysis, because that's where the safety is not fully defined. So there's no longer just a 30 or a 60 or a 50 or whatever creatinine clearance cutoff. Any creatinine clearance without dialysis will be allowed. Similarly, we have dropped, for example, some pre-registration treatment. For example, up to 1 cycle of non-daratumumab containing regimen will be allowed. Localized palliative radiation is allowed. I mentioned any degree of kidney function. There are slightly different criteria for whether patients are frail or intermediate fit. You can see that ANC of 0.75 or higher is allowed. The patients don't have to be at 1. Platelets of 50,000, hemoglobin 7 or higher rather than 8. These used to be typical criteria, but we have really addressed a lot of them. If the patient comes in and could be treated with one of these regimens, they should be able to go on study. And these are, of course, our contacts. I should also quickly point out that as we are doing this, SWOG has really taken on, for example, the role of our DEI, diversity, inclusion, equity. So we have a DEI champion for our committee, and he has been working with me to craft a DEI plan around this study. And we hope to be able to not only define what we're doing with our minority accrual, but also hopefully we'll be able to figure out why minority accrual is lagging behind, or hopefully it is better than expected. So that is something being worked on. I mentioned PRO. Christine's working on the TM plan, the translation medicine plan, and then we have a financial toxicity component. And importantly, I think there is the VTE sub-study also. Anything else you want to add? Yes.
Maybe we can just mention that we have a VA champion, Dr. Chelsea. He is on the Zoom as well. And it is a great effort from him to be able to include our sites from VA network. And we are very excited about that.
Absolutely. And I think that's, again, something to highlight from a SWOG standpoint. There is this effort to try and make the studies more VA friendly. So 2209, along with a different study from the prostate group, have been are kind of spearheading that work. So there will be language in the protocol that kind of makes it quote unquote VA ready or VA friendly. Again, the idea being we would like our studies to be open and be as inclusive as possible. So kudos to obviously Dr. Chauncey to be the champion from the VA standpoint. We already have an ECOG and Alliance champion also. So hopefully once the study is ready, right now we're waiting for the final approval from NCI and CIRB, and a pre-activation amendment is being worked on. As soon as we get those approvals, pre-activation amendment goes in, gets approved, and the study should be available at a neighborhood site for everybody. Anything else from you, Christine or Bob? Anything that you would like to add?
I was asked to comment on the VA side, and I think unfortunately, it's a little premature. As you can imagine, the VA is a complex organization with lots of priorities at every level, but there is support at the top for cooperative group studies. And what I've been trying to do is get that support to filter down. And hopefully well before the next meeting, I'll be able to comment in more detail on that. There are at least 15 sites that are SWOG ready for any trial, and it's going to be easy to target them and see what their interest is for a particular trial. But this idea of supporting cooperative group trials, it obviously goes beyond myeloma, and it's an important agenda that I'm trying to push through, and we're all trying to push through. I mean, it's really all of our tax dollars at work here.
And I just want to there was a couple comments for those of you in the room who are not online. Sarah Salter said that it's very promising from a community side perspective. And Dr. Orlowski said it's wonderful having the VA involved would be great.
Excellent.
And also one more update from the imaging committee. They are very supportive as well for another correlate study using imaging analysis.
Perfect. So again, Christine is also working on the imaging sub-study, which is, the idea is that and this is not just for this trial, the idea is that we want all these components to be either built in or prioritized in our mind. What would be going into a trial pre-activation, what could be done post-activation, but at least all the pieces are in place, like imaging is already built in, and we can hopefully work on an analysis later on. And so yeah, hopefully the study will be able to open up very soon. Please, there are a couple of questions in the room. Please go ahead to the mic and yeah.
Any concerns that as patients stay on induction, they go into a good remission, performance status goes up, if they become then, quote, eligible for transplant, the treating physicians will want to treat them? I know they had this problem on a previous ECOG study and had to significantly increase the sample size at one point to account for those dropouts.
Excellent question. So we have looked at this, and that's why the idea was to use this myeloma frailty index. And the idea being that some of these patients would probably have had some of the treatment, so that improvement in performance status would have already been seen in some, if potentially that is going to happen. That is certainly something we have kept in mind, and we have pointed it out that at the time of our interim analysis, we will be looking at that very intently. This study is geared towards a population where we thought that the number of patients who may cross that threshold and become transplant eligible would be relatively small, but we have kept that in mind. And if we need to account for that down the road with accruals, we'll see. But Christine, any thoughts from you from anything else that comes to mind? We've talked about this a couple of times.
Right, I totally agree with Dr. Al-Dawadi, his comments, because there's another study actually from ECOG, and that patient population actually is a more intermediate fit patient population that probably will fit into the category that you mentioned, that their performance status might be better after the induction therapy. Our patient population is designed more like frail and also low intermediate fit patient population. And we relaxed the parameters for inclusion criteria so that we can include a real world patient population.
But excellent question, and absolutely, please.
I'm surprised that Jensen found that people drop rather DARA than REV. And in my experience, in my talking with the people, first thing you drop is REV.
Excellent point. So for sure, the real world population is not following the Maya paradigm of continuing everything. And you're right in pointing out that in real world, maybe REV gets dropped before the DARA because the DARA is being better tolerated, et cetera. But this was looking at, or the way that was set up was based on, so I guess why would in arm 2, we not continue with DARA maintenance as against REV maintenance, which is built in? So if coming to that, to your question, this purely came from that market scan data that they were able to actually share with us, that the average time that a patient stays on DARA in an induction setting, especially in this population with the DARA Lendex of a start, is somewhere around 7 to 8 months. And so I agree, when we heard that, we were exactly similarly kind of astonished that, are you serious? That's true, but since it was coming from them, we kind of believed it. Okay, excellent. So I guess with that, we'll go on to our next study, and I'm gonna ask 2213. Oh, yes.
I would just say quickly that, you know, one rationale I've heard from folks to stop the DARA as opposed to the LEN is that they like to be able to then reuse it at the time of relapse. And of course, the LEN is easier to continue being oral. And they think that by saving it, you could then use it, for example, with POM at first relapse.
And perfect, Bob, yes. And actually, that reminds me, one other thing that had been brought up was that a lot of these patients, which was again a thought brought up in one of those discussions, was that a lot of those physicians or patients then consider even going to an every 3-month clinic follow-up, and just more like a maintenance post-transplant kind of a picture. So less visits, less treatment, et cetera, et cetera. So with that, we'll go on to the next one. I'm going to ask Patrick Hagan to come and talk about S2213.
All right, thank you. Interestingly enough, there's similar data on Andromeda inductions where providers are stopping the DARA and not continuing the maintenance there. So I believe that the notation that a lot of people are dropping it. So. But to switch gears a little bit to a different disease, but an important one nonetheless, this is a study that's been in development really more aggressively over the last year, and it's kind of finally being pushed towards the finish line, hopefully. So this is a study looking at optimal consolidation therapy in amyloidosis. So with the recent registry approval of DARA-VCD and amyloid, we really have an established probably standard of care, most would argue, for induction. And with good responses, you know, the biggest question, and it's been a question ever since I've been treating amyloid, is, you know, really what is the role of consolidative autotransplant? So this is a randomized phase 3 study that's really trying to ask that question in a formalized manner. And as the slide shows, this has really been a big collaboration, really nationally and internationally. We've had formal champions from the other cooperative groups. We actually now have formal endorsement from the BMT-CTN, and recently the CCTG has joined with hopefully formal endorsement there soon, but active involvement in the protocol development. So, which is important in this rare disease, obviously. So kind of moving forward, so this is an endpoint that was developed on the Andromeda study and will be utilized in this study. This is called the modified PFS, and essentially this is a composite endpoint looking at really the important outcomes in amyloid. And with the rare disease where patients do really well, often for a very long time, particularly transplant eligible patients, doing an overall survival endpoint, or really even just a hematological progression-free survival endpoint, was prohibitively long. And after some feedback and kind of discussions again with the group and the NCI, this was chosen as the endpoint of this study. And so the endpoint can be met by several events. One is hematological progression, 2 organ progression, so renal and cardiac, and then overall, and then survival. So this is the primary endpoint of the study. There's a lot of important secondary endpoints, some of which are encompassed in the primary endpoint. But in addition, we're going to be looking at important quality of life metrics. And I think this is critically important because this may very well be a study where we see a very similar outcome. So quality of life may actually dictate patients' decisions for their treatment in the future, as well as physicians. We're going to look at minimal residual disease. This will be done both by flow in the marrow, post-induction, post-consolidation, and then 1 year post-consolidation, but also by peripheral blood mass spec every 3 months in patients who are in at least a VGPR. And then we're going to look at treatment-related mortality. So not just deterioration of patients who get a transplant, but unfortunately, amyloid patients, even with standard of care, can unfortunately have organ progression and even death, unfortunately. So here's the formal treatment schema for the study. So essentially, this is standard-based induction with dara-VCD based on the Andromeda protocol. All patients, once they're registered and eligible, and I'll show eligibility on the next slide, will get 3 cycles of dara-VCD induction. At that point, they'll head towards registration step 2, which is where the randomization occurs. Again, if they're still eligible for transplant based on the second set of eligibility criteria, they would be randomized in a 1-to-1 fashion to essentially complete the Andromeda protocol, so 3 additional cycles of dara-VCD, or randomized to high-dose chemotherapy, melphalan, and autologous stem cell transplant. Following that, all patients will go into 18 months of maintenance daratumumab, both in the transplant arm and in the dara-VCD arm. We are not mandating stem cell collection, but we're allowing enough time in the protocol design for patients to collect whether they're randomized to transplant or not. So it's 6 weeks after that registration steps till they're assigned, a maximum of 6 weeks after they reach step 2 till they're assigned their arm, and then we're allowing up to 8 weeks after that before they start their consolidation. Obviously, transplant workup takes longer, so those randomized to the non-transplant arm would move forward quickly, but again, we're allowing that flexibility so providers can collect stem cells if they choose to. And then patients who are not deemed eligible at that second step will be followed on a registration basis, but they would come off study. So these are the key eligibility criteria at enrollment, so step 1 registration. Really, these are pretty standard, so they have to obviously be eligible for transplant. As designed right now, we have an upper age limit of 70, although that may be up for debate depending on how enrollment goes. They have to have obviously biopsy-proven amyloidosis. They have to have measurable disease. And then one thing that is different on this slide, there's a difference in the free light chains. We've actually dropped down to 2 in the eligibility based on some recent data on being able to measure response in those patients. And that can account for upwards of 20% of amyloid patients. They tend to be transplant eligible, so we felt that was an important change that happened recently. They have to be transplant eligible based on their cardiac markers, so both NT-proBNP as well as troponin markers. And we understand in many centers around the country, the practice of which troponin and which BNP or NT-proBNP is being obtained is variable. So we're actually allowing for both with conversions. But these are validated markers in terms of transplant eligibility. So it's all blood pressure greater than 90, and then some standard organ criteria that are listed here. So then after they get their 3 cycles of induction therapy, then they have to be eligible for transplant still. So essentially it's the same criteria, but in addition, they have to have at least a partial response to their induction therapy. So we wouldn't want patients who got 3 cycles of dara-VCD and had stable disease to go on and get 3 more cycles of the same treatment. And response times in this regimen are actually very quick. Actually, median time to CR on the Andromeda study was only 2 months, so about 2 cycles. So after 3 cycles, if you've not achieved at least a partial response, you would not be eligible for randomization. And then I guess the only other unique eligibility then would be the ability to collect stem cells for transplant, at least 2.0. So again, it's possible there would be a rare patient, although this shouldn't happen too much with just 3 cycles of therapy, who wouldn't be able to collect. So they have to be able to collect adequate stem cells for transplant if they're randomized to that arm. So here's our methodology. So this is, again, it's an experimental arm, which is the high-dose chemotherapy and transplant compared to the dara-VCD consolidation arm. We're assuming based on the data that's been published in the Andromeda study, which is still a little bit early, But our estimates are a 31-month MOD PFS in the Thera-VCD arm compared to 50 months in the transplant arm. And so again, this is not just hematological progression, organ progression, survival, all these count as events toward that MOD PFS endpoint. So we're anticipating about a 15% drop off of patients that will be registered but ineligible. Again, that's basically lack of a partial response after induction and then not meeting transplant eligibility at that second step. And we're looking to, and this is a typo, it's 169 patients per arm that would be registered to account for that 15% drop off to ultimately randomize 143 patients per arm. These are our stratifications. So the European modification of the Mayo 2004 staging system, which again captures really cardiac. So we want patients with cardiac involvement to be stratified. Hematological response. So patients who have achieved at least VGPR or better versus PR are stratified. And then translocation 1114 in the bone marrow, because there is some data that there's differences in responses between those who get a transplant and not. We have, like I said, a formal quality of life sub-study that's actually just finishing in development. This will be administered at baseline. The primary endpoint of that will actually be post-consolidation, a global assessment of quality of life. But there's a bunch of other CT-CAE assessments we're going to be looking at, like diarrhea, neuropathy, pain, shortness of breath. These are all important endpoints as well. And then, like I said, I think we have a really nice translational study set up here to look at MRD in the bone marrow as well as peripheral blood every 3 months. And this is a really unique opportunity to do this prospectively, and potentially with some growing data and mass spec-based peripheral blood assays, we might be able to really give pretty powerful prognostic markers to these patients without the need for repeat bone marrows. So again, I think some nice correlative studies, nice PROs that are being built into the study to travel along with the primary endpoint. And here we are with the timelines. Like I said, this study had a little bit of a delay at the NCI, unfortunately, so we've been kind of moving very rapidly, very quickly, with a lot of support from various members of SWOG, which I've really appreciated. I think we're going to be able to stick to these deadlines, and we have a planned PRC actually next week. So I think with that, yep, that was my last slide. So that's amyloidosis in 5 to 10 minutes. Anybody has any thoughts or questions? There's obviously a lot of controversy in this disease and kind of even in this trial design. So there's no perfect study, but we think this is a study worth doing.
As you know, with the transplant, we see these transient increase in creatinine or maybe transient even drop in cardiac function or jump in NT-proBNP if the patient has a fever or something like that. So how do you address that?
Yes,
in the transplant arm especially.
Yeah, great question. So in both arms, if they have a defined event with the exception of survival, those markers have to be repeated 4 weeks later to be counted as a MOD PFS event. So. So we'll keep everybody posted. I highly encourage everybody to open the study at their sites, obviously. And, this will be a study that's going to take a lot of communication between transplant centers, community centers, referral centers. But I'll tell you, this is a question that's really becoming pressing in the clinic right now. So if anybody has any questions or thoughts, please feel free to email me. We're always looking for more input. It's really helped the design of the study. And thanks for coming to Chicago.
Thank you, Dr. Hagen. If anybody needs a recommendation of the local restaurant, he can be the one. So after the listening to the last 3 studies, we have 1 active study, 2 upcoming studies that are going through the regulatory process. We will be discussing 2 concepts that we would like to share with our audience. The first one would be the high-risk multiple myeloma concept, and it will be presented by Dr. Lipey, and I believe she is on the Zoom. Dr. Lipey, would you like to take over?
Yes, can you hear me? It's Lipe.
Yes, we can hear you. Thank you.
Okay, great. So basically, we've been talking about a trial for newly diagnosed high-risk multiple myeloma for many years now. and this trial has undergone different iterations. And this is the current iteration that we have. So as we know, multiple myeloma remains incurable, and patients with high-risk disease have a reduced progression-free and overall survival. So the idea behind this trial is that if we add some of our newer agents, maybe we can improve responses. So this study looks at adding the drug called teclistamab, which is an IgG4 bispecific antibody to BCMA CD3. It induces T-cell mediated death of BCMA expressing cells. So this is our bispecific T-cell engager for BCMA. Next slide, please. So the primary hypothesis, I can't get this full size on full.
You can tell us, Brea, and we'll move the slides.
Okay. My problem is I can't read the slide. So the primary objective is to compare overall survival, and the overall survival is going to be between our standard of care arm and our experimental arm. So we're going to look at the overall survival of patients who are randomized between RVD-DARA induction versus RVD-DARA teclistamab induction. Some secondary objectives that we're going to look at progression-free survival between these two arms, and we're going to compare response rates. We're going to look at toxicity. This trial has planned maintenance that's going to be dependent upon MRD status. So we're going to look at some endpoints around that MRD status in terms of the outcomes for patients who achieve MRD negativity versus don't, and those patients who are MRD negative with one therapy versus another. We're also going to look at some health-related outcomes for this trial and looking at quality of life. We have some other things that are planned to incorporate later with this trial, including assessments for financial toxicity and feasibility, and some other correlatives looking at likely imaging and the tumor microenvironment. Next slide, please. So here, so the eligibility for this trial, it's similar to what we've seen in the past. It's basically patients who have newly diagnosed multiple myeloma. They must have measurable disease. Plasma cell leukemia is excluded. 1 cycle of prior therapy is allowed. This is for patients with high-risk disease, and we're defining that as RISS stage 3, or with the revised ISS criteria, those patients who are high risk by the revised ISS criteria, as this will allow us to gather some patients who have these gains of 1Q. So this is the current population that we're targeting. Next slide. So this is the schema of what we're proposing currently. So again, 1 prior cycle of therapy is allowed. Patients will be randomized 1-to-1 between RVD-DARA versus RVD-DARA teclistamab. Patients will be allowed to have stem cell collections after about 3 to 6 cycles, as these patients can be transplant eligible and still be eligible for this trial, with the idea being that upfront transplant is delayed. So after 12 cycles of induction, patients will move on to maintenance therapy. At this time, at 12 months, they will have MRD assessments by flow, next-gen flow. Patients will go on to maintenance, which will be either RV-DARA versus RV-DARA tech. And then those patients who are MRD negative at that 12-month mark are eligible for another assessment of their MRD status, and patients who are MRD negative ×2 will be changed to lenalidomide bortezomib maintenance alone. Next slide. And so one of the things that we've talked about is sort of the best way to plan for this induction therapy, with understanding that these are treatments that are time intensive and require a lot of commitment from the patients. So we'd initially planned to do bortezomib on days 1, 4, 8, 11, and now we're going to switch that up to weekly therapy just to minimize the amount of times that patients have to come to the infusion center. The lenalidomide will be then days 1 through 21, and the dexamethasone will be given in the first cycle, with the idea that we're going to taper off the dexamethasone after the second cycle, because we don't want to risk interference with the teclistamab for the teclistamab containing arm. And then for patients who are on the RVD-DARA tech arm, the teclistamab will start with the step-up dosing for cycle 1, and we'll probably do that a little bit separately from when we start the RVD-DARA, just so that we're able to get patients through their step-up dosing and minimize interruptions as they have to be hospitalized for their step-up dosing. Next slide, please. So then the maintenance, so the RV maintenance will be pretty standard. The bortezomib will be days 115 and the lenalidomide will be 15 milligrams for 21 days on a 28-day cycle. Those patients who are on RV DARA will have their daratumumab continued monthly, and those patients on RV DARA-TEC will also have the teclistamab given on days 1 and 15. Next, I think that might be all the slides. So that's sort of the reiteration that we've undergone now. We're planning for about 230 patients to be enrolled to this trial. And any thoughts that anyone has are welcome at this time. So hopefully as this moves forward, stay tuned. And we're excited to hopefully get something moving forward in this high-risk space, which is something we've been looking at for a long time. And if anybody has any questions or concerns or thoughts, feel free to reach out. Thank you.
Any questions?
No, I think there are no questions that came up, but this is, this design is, or this current version is now being put into the capsule, or Brea is working on it. So of course, if anybody has feedback, please reach out to her. It'll be extremely helpful.
Yeah, because bispecific antibodies still haven't been approved by FDA yet for multiple myeloma, and we are anticipating the first drug to be approved probably soon, but we have a lot to learn. Currently, it's a very tight space for clinical trials, especially targeting BCMA. So any feedback from any colleagues, that would be very welcome, and shared with Dr. Lipay. All right, so we have another concept in development, and Dr. Bhutani is leading that study design. And so this would be our third amyloidosis study. So we are very excited to hear about this development.
Thanks everyone for allowing me to present this. So this is the concept that we have been now discussing for some time and has been presented before in this meeting. So this is a trial, a randomized trial of KEL-101, which is an anti-amyloid antibody compared to placebo in patients who have history of renal AL amyloidosis. So the slides are a little bit, okay, let me just go back.
It's very sensitive.
I guess the slides order is quite. I think the slides kind of got mixed up a little bit, the order of the slides.
So
I have a different version.
So we have. If you log in and then share the slides. Give us just a second. I think we'll bring up the updated version.
We are joining the Zoom meeting so that we can share the slides.
You need to stop sharing here.
It's showing online on Zoom, but not
I
showing
think
on
that
the screen.
is picking up from.
Would you be able to pick up from the Zoom share?
Yeah, yeah.
There it is. Okay, cool. Nicely done.
Okay, thank you. Okay, great, thanks. So as you guys know that, advanced AL amyloidosis continues to have, very poor prognosis. And even though, on the graph that you see on the left side, this is sort of over time, in the most recent era, although the overall survival is improving, you can see there is a rapid fall off or rapid mortality of patients who have advanced cardiac disease. Furthermore, the patients who are able to achieve hematologic and organ responses, the organ response, tend to be delayed. And it can take up to an average of, north of 10 months to achieve an organ response after hematologic response. Next slide. So the question we are asking is, will monoclonal antibodies targeting amyloid deposits, improve the outcomes of patients who have renal AL amyloidosis? Next slide. This is some of the data that has been seen previously. This was a molecule that was previously tested in two phase 3 studies, NEOD-001, which is a slightly different anti-amyloid antibody in the way it worked. This was a trial that did not meet its primary endpoint, which was cardiac response, but in the trial there was a significant difference in renal response rate, which increased almost by 20%, went from 33% to 53%. There was, based on this trial, concurrently there was another trial opened at Tufts University by Dr. Comenzo, which was looking at NEOD-001 in patients who had persistent renal dysfunction, and they enrolled 11 patients, and 2 out of 6 patients had an excellent response, and 1 patient actually had a major drop in proteinuria from 17 grams to 4.9 grams after 3 months of therapy. But this study was also stopped after the NEOD program at that time was stopped. Next slide. What is KL101? This is an antibody that primarily binds to this loop. As the amyloid protein undergoes deposition, it undergoes this loop formation, and that's where the antibody was developed to bind to that loop and potentially cause, then after the binding, induce the immune system to remove the amyloid protein. Next slide. So this is the loop flip where the antibody will bind. This is the work that was previously done when this molecule was developed in University of Tennessee. And this is PET scans of patients who received this antibody, showing that the antibody is able to bind the amyloid involved organs. On the left side, you can see a patient with the liver and bone marrow amyloid, and the antibody is able to show specificity to binding to those organs. On the right side, we show same patient with the biopsy of the liver as well as the bone marrow with binding of the antibodies. Next slide. Based on this, we completed a phase 1 study of this drug at Columbia University Medical Center, and this was published in Blood, and we were able to show both cardiac as well as renal response. Renal response happened in about 50% of the patients, and cardiac responses were seen in about 67% of the patients. Next slide. There is an ongoing phase 2 trial that was presented at ASH a couple of years ago at Cleveland Clinic, where the MTD established at 1,000 milligram per meter square weekly for first 4 weeks, and then every other week after that. And this is the data from Cleveland Clinic, and they showed a very high incidence of renal response rate in almost every patient responded. And you can see the 4th patient had a close to an 80% drop in proteinuria after receiving this drug. Next slide. This is the safety data from our phase 1 trial that was done at Columbia, and the drug was very, very well tolerated without any significant grade 3 or 4 toxicity. Next slide. So this is the design. Currently, the company, as you know, Alexion is currently conducting 2 cardiac studies. So because of that, we are primarily focused in this trial on renal patients. We are going to enroll patients who have been previously treated with the anti-plasma cell therapy and have achieved a hematologic response, including a CR or a VGPR. have a persistent proteinuria, which is mistaken here. It has to be more than 1 gram over 24 hours. And then those patients will be randomized 1-to-1 in a double-blind randomized fashion to KL101 versus placebo, treated for 12 months. Right now, we're having some discussion about the duration that may extend to 24 months with the primary outcome of renal response rate, which is based on proteinuria in the absence of worsening renal function. And then secondary outcomes, which will include cardiac response, overall survival, safety, and patient-reported outcomes. Next slide. I already went over these. Primarily, the primary objective is going to be renal response rate, which is typically defined in this population by a 30% drop in proteinuria without concurrent increase in decrease in GFR, and the secondary endpoints that we already talked about. Next slide. This is the eligibility. We will allow patients with the known history of renal AL amyloid, and that does not have to be biopsy proven, as long as the patients have proteinuria without any other clear cause of proteinuria in the opinion of the physician, the patient will be eligible. The total proteinuria has to be more than 1 gram over 24 hours at the time of enrollment into the study. Patient has to have at least 6 months of prior anti-plasma cell therapy. That could be a physician choice. We are not going to mandate what they should have received, and they must have achieved a complete remission or a very good partial remission at the time of enrollment. We will allow up to 2 lines of prior therapy. We did want to have some time between the patient completing their plasma cell therapy and going on to this study. So we will require at least 16 weeks from the end of last treatment to enrollment. For patients who are undergoing transplant as upfront therapy will also be eligible, but we will require 24 weeks from the date of transplant to enrollment in the study for those patients. Patients who are on maintenance with daratumumab can continue as the maintenance as per the discretion of the treating physician. Similarly, patients who are getting second-line therapy, they can also continue a CD38 maintenance as per patient and the physician requirement. And then we will have standard sort of hematologic and hepatic parameters. eGFR of more than 30 is required to be enrolled. Next slide. We will exclude patients with the NYHA class 3 or 4 heart failure, NT-proBNP of more than 8,500, and ejection fraction. We are probably going to modify that to 35%. Rest is fairly standard. We will exclude any patient who has received an anti-amyloid antibody before. Currently, there is, as you know, 2 ongoing trials with KL101 and 1 ongoing trial with NEOD-001. So those patients will not be eligible to enroll on this trial. Next slide. This is the treatment schema. This has to be a blinded study because if we enroll patients who are going on placebo and either the patient or the physician know their sort of interest in remaining in the study goes down dramatically, there will be 1-to-1 randomization. KL101 will be given at 1,000 milligram per meter square weekly IV for cycle 1, and then every 2 weeks for a total of 1 to 2 years. We probably end up at 2 years, and then there will be additional follow-up of 2 years. This is the primary endpoint and secondary endpoints, which we already discussed. Next slide. So if there is possible that some patients may have hematologic progression while they are on the study, as long as they don't have organ progression, which would be either cardiac or renal organ progression, they can continue to receive the drug on the protocol. Any patient who has organ progression will be unblinded, and if they are on placebo arm, they can potentially cross over and start on KL101. This will possibly increase the interest of the patients to enroll on the trial. And those are on KL101. Obviously, if they have organ progression, they will be taken off this trial. And patients who cross over can also potentially start an anti-plasma cell therapy as per the discretion of the treating physician. Next slide. This is the sort of the numbers that we have run to calculate the N for the study. So we assume that patients in the placebo arm will also continue to have some renal response rate, given that we do see a significant amount of renal response in patients who just received anti-plasma cell therapy, which is close to 55 to 60% on the Andromeda trial. So we assume that given that these patients are not being enrolled upfront, that in the placebo arm, we will see about 30% renal response rate. And we hope to improve that to around 50% in the experimental arm. And based on that, with a power of around 80% and a one-sided alpha of 10, we will require about a total of 140 patients to be enrolled, with 70 patients in each arm. And these are the stratification factors, including history of transplant, DFLC of less than 1, renal stage 2 and 3, as well as a prior history of organ response. So those are 4 stratification factors. We want to sort of make them even between the 2 arms. Next slide. This is accrual based on a previous study that we completed at SWOG with isatuximab, and we enrolled, I think, about 3.5 patients per month in that. So based on that, we calculated, we will calculate the number, sort of the years of enrollment and follow-up. But we hope that we will be able to get that to that number, given that the previous trial was just done in SWOG, but we will be able to open it SWOG, ECOG Alliance, and possibly VA as well. And we are planning to planning a futility analysis. When 50% of the patients have been treated for at least 6 months, we will do a futility analysis at that time to assess the efficacy, with potential to stop the study at that point if we don't see a predetermined efficacy from the or predetermined difference between the experimental and the placebo arms. I will stop there and take any questions or suggestions or comments. Yeah.
Dr. Bhutani, Jack has a question on Zoom. In myeloma, I'm told that no longer patient has renal insufficiency, less likely renal function improves when myeloma treatment is effective. Is this also the case with AL amyloidosis? And if so, length of renal insufficiency is a consideration in this study?
So I think from what I understand, if I understand the question correctly, the question is in patients with myeloma who typically present with cast nephropathy, if the duration of cast nephropathy is not more than 6 months, they have a very high chance of reversal of that renal function. The mechanism of renal dysfunction is AL amyloidosis is very, very different. It is primarily not cast nephropathy and primarily deposition of this amyloid protein in the glomerulus. It is true that the patients who do, it is not known, whether the duration of that renal dysfunction plays a major role in this situation. So that is less of a factor, I think, in this disease. But the patients who do present with the higher renal stage, which is sort of their GFR being less than 30 or proteinuria of more than 5 grams a day, do tend to have worse renal survival, which means they have a higher chances of ending up in end-stage renal disease and dialysis. I don't know if, Jack, that answers the question. But it is different from myeloma. Yeah.
Jack says thanks.
Okay. Anything else? Thank you.
Thank you, Dr. Bhutani. It's very exciting to see that we actually have one amyloidosis study, the first one relapsed or refractory, 1703, led by Dr. Parker, which we finished the enrollment and presented at different national and international conferences. And the manuscript is in preparation, so hopefully we will see the publication soon. And then we have the second amyloidosis study led by Dr. Hagen that to compare transplant and standard of care. And also now we have another drug with the new mechanism of action. Hopefully those will benefit the patient, amyloidosis patient, and also advance the treatment paradigm for AL amyloidosis. With that, we will, oops. Sorry. Because we updated slides, but looks like our AV staff did not receive our updated slides. Okay, so would you like to?
Christina is not on.
Yeah, that's right. So Dr. Gowan is the champion for, so we have 3 ECOG studies, and Dr. Gowan is the SWOG champion for this EAA 181 study, also known as EQUATE study. So this is the study to start with the induction therapy, DARA-RD triplet for 9 cycles, and then check MRD status of each patient. And then patients will be randomized to either quadruplet DARA-RD plus Velcade versus DARA-RD, and followed by the maintenance therapy. So the most updated accrual status, we have 106 patients enrolled with 165 patients screened so far. So hopefully we can get all the sites to enroll more patients for this study. And the next one is EAA 171, and I'm serving as the SWOG champion for this study. It's also known as Optimum study. And this is a study as post-transplant patients checking MRD status, and if they are having MRD positive, then they will be randomized to 2 different arms. And one is the standard of care with RAV only, and the other one is RAV plus Ixazomib. So far, there's only 1 patient enrolled. Actually, we would love to hear from all the sites if there's any difficulty with screening patients or enrollment. Any feedback will be appreciated. And I will let Dr. Manaset to talk about the most update for EAA 171, which is deter for smoldering multiple myeloma patients.
So we have a randomized study for smoldering myeloma patients with the combination of lenalidomide with or without CD38 antibody, daratumumab. And what we have here, these are kind of newly diagnosed high-risk patients. So they must have been diagnosed within 12 months of study entry. And then patients are randomized to receiving daratumumab and lenalidomide dexamethasone, or just lenalidomide and dexamethasone for 24 months, with dexamethasone being given only for 12 months. And the main goal of the study is to look at the response rate, including complete remission or partial response. And then if there's progression at time, of course, the patients come off study. 288 is the planned accrual for this study. So far, we've accrued 118 patients. So I think the study is doing quite well. And there's a lot of correlatives as well as secondary endpoints such as MRD, and also looking at imaging with MRI and PET-CT in this population. And it's about that. Yeah.
Excellent.
Thank you, Dr. Manaset.
So I think that was all the studies that are ongoing, those that are planned to be opened up soon, and some of the concepts that are being developed. I know there was a slide that showed up about 1114 venetoclax relapse refractory. So that was a very preliminary discussion that we had yesterday. So we don't really have a formalized concept yet to discuss around that space, but that was something that was just a discussion that we had yesterday. But as things pan out or they develop, of course, we'll be bringing them back to this committee, because the feedback from this group has always been very, very valuable and helpful. Any other thoughts from anybody? Bob, any comments, any thoughts? I guess I think whoever's online, thanks a lot for joining. Thanks to those who are here in person, and we look forward to continuing engagement and also continuing participation in future meetings. Thanks, everybody.
Thank you.